Thank you, sir. Uh, Let me start off where I stopped. The basic checkup of any refractive surgery includes looking at the visual quality, the topography, and the wavefront. The most important thing is we all started with just this much when the refractive surgery was first introduced, the Placido-based system. But however, we realized that the time has changed and it keeps changing. So our diagnostics cannot be the same as what we used 15 or 20 years back. The reason is the patient perception of doing a refractive surgery is completely different from your perception. For example, if you're looking at the patient expectations, the entire statistical parameters, what you see, for him is all 100%, and there is zero complications, compared to what is realistic from a surgeon's point of view. So what is important is the biggest assessment what you need to do is trying to understand your patient. Many times we try to start with the diagnostic, we try to look at the topography, and then we'll try to see whether the patient is fit or not. But I believe you have to do a little bit of a psychological assessment of the patient, because if you do not do it, you will have a very, very unhappy, terribly dissatisfied patient. So what I teach for my postgraduates and fellows is that the time has come for us to understand or read our entire optics. About what we were reading as an optics in our post-graduation was more of geometric and more of clinical optics. Now we have come to an applied optics, because there is the most important foundation for any refractive surgeon or anybody doing refractive surgery is the quantity and the quality are not the same. So when a patient comes to you and you are making him read your Snellen visual acuity chart in a bright lit room, he's reading 6 by 6, but he still crips. He says, I'm unhappy with it. It may be a post-cataract surgery, glaucoma, retina, whatever you want. The most fundamental part of any refractive surgery or any ophthalmic surgery is there is a huge difference between the quality and the quantity, because that is what differentiates an happy versus unhappy patient. So my talk here, for the first part of my talk, is basically trying to understand the diagnostics, what you need to know or what you need to apply in your practice, which starts with your tear film. One of the most important optical element in our eye, we all say is cornea or lens, but it's actually your tear film, because it completely changes the quality from good to bad. The quantity may still remain the same. The patient may have a 6 by 6 vision, but its quantity, the quality completely changes. That's what the tear film is. And that is linked to the optics. And we have to understand that whatever we do on our tissue, on our eye, especially the cornea, it's a biomechanical tissue. That means it has got a stress and strain relationships. So it will not behave the way you want. It is not a rigid tissue, not like a wood. So that is something which is a new way of understanding. I'm not really going into the basic evaluation of tear film. What we're trying to see is the future of evaluating is actually trying to quantify. Each time the patient blinks, you see colors out here. Each of these colors have a pattern, and there's a permutation of combination of 1 billion permutation of combination, and that is given you by this pattern, and it gives you a value. That means it just tells you the quantity of lipids in your tear film. It's actually, you don't need to do all this. I'm just trying to, it's a Shermer's tree, but still enough as a gold standard for your refractive patients. But this has already been covered by Dr. Geeta. So I've just thought, what are the future directions of trying to understand the tears itself? And when you lift up your lids, and if you use an infrared light, you'll see these meibomian glands. And these glands are the ones which actually helps to give you a good quality of lipids. And that good quality of lipids keep your tear film intact, reduces the breakup time, and gives you that quality of vision. Imagine a person who has absolutely no meibomian glands. We call it as meibomian gland dropouts. And what you see here is a completely bland tear film. That means there is no lipids at all in them. And what happens to it is there are technologies today which helps us to evaluate how much of your quality of vision is coming from your tears. And this is very, very important for us, because we sometimes ignore tears. Tears are called the phantoms of your vision, because it's there, but you just don't care. So what happens is, in this technology, in just 30 seconds or 40 seconds, you'll try to know how your quality of vision is affected by your tears, because it takes multiple photographs, images in a spurt time, and then it tells you the quality of vision which is causing the scatter. That means at one shot today, you can do three things. You can look at the lipid layer in your tears, which is probably the most important for evaporative dry eye. It helps to look at the meibomian glands. The meibomian glands are necessary for the health of your tears. And the third thing is, if you want to quantify how much of my vision is actually changed because of a tear film, we have technologies to do it. So virtually at one shot, you completely understand the whole pathophysiology of the tears. After you're looking at the tears, the second most important thing is trying to look at the topography. Like I said, the era of Placido, it's a great technology. It just works on the reflection of light, but that era is old. It's gone. We need to look at, because it had multiple things, it had a huge central camera in the thing which would miss a lot of data. The peripheral data used to miss. People used to miss a lot of peripheral changes, and that used to cause a lot of complications of LASIK. So then came a new interest, which was actually a borrowed science from the mapping, the mapping of from the earth, and when you map, the geographical mapping. There, when you map, anything in a reference is always coded in green. Everything has to have a reference. It's always relative. You compare one to the other. And anything which is above is coded always in red, and anything in the sea level is always in blue. The same colors were used when you're trying to look at the topography. This is exactly what I meant. So when you look at an op scan, it tells you the elevation, the back of the cornea, the posterior elevation, the pachymetry, and the curvature map. You can have multiple combination of maps, but this is what everybody looks at. This is what you get in exams. This is what you need to know. And again, the same color combination applies here. Anything in green means you are looking, it is matching with the reference. Anything in yellow means it's a little higher, and anything in the red means it's higher than the reference peer. And every value is on this side here, and you can just, even if you put a cursor, you'll get a value here, so you don't really need to worry about it. So what is basic here is that everything has to have a reference, and the colors are always reference coded. And that is always the confusion when you're reading a map. And either you look at an op scan or you look at a pentacam, it's all color coded and all the same colors, and all the colors have different values here, and you can just see that they use different numbers because each company wants to create an exclusive way of representing a scan, but that actually confuses all of us. But still, it's the same anti-elevation, sagittal curvature, the anti-elevation, the post-elevation. When you see red, if you look at this, blue is always in minus, and anything in plus means it's higher. So if you look at the blue area, that means this area is lower. It's at the sea level compared to this area. This is like a mountain. So that is how you look at a scan. So when you actually see a scan, so if you look at it, and it will be self-explanatory, because you can read any scan, because that's all we look at, and then try to correlate this area with the pachymetry changes. What is interesting now is, for many, many years, we were trying to look at the topography but never bothered about the epithelium. Epithelium, it's actually around 50 to 60 microns, and it can unmask a lot of changes happening in your cornea. And for a refractive surgeon, it's very important because, for example, in this case, you have an epithelium in the center, which is 76, and this area is 53. So there's a lot of difference in this epithelial profiling itself. It can change in dry eye. It can change after refractive surgeries. These changes are actually having a change in your refractive error. For example, if you see it's a 73 and 52, that's close to around 20 microns difference. This epithelium itself is changing the patient's refractive error by a -1 diopters of cylinder. And that means many times you're trying to wonder, where is the cylinder coming from? I'm not getting, it keeps changing and all that. It may be related to the epithelium. So this is something which is very new understanding. Epithelium can also play an important role in your change in your refractive error. So without understanding the epithelium, trying to make a diagnosis of those complex cases which progress may not be very helpful. And in this case, there's a lot of changes happening. In this case, for example, you see the center of the epithelium is around 55 to 60 microns. Sometimes when you have a thicker epithelium, like in this case, the center is thin, the periphery is thick. So what does it do is actually creates a tremendous amount of optical irregularities. So why I'm trying to bring this out here is that you need to understand there are machines, common machines which can do epithelial mapping, and the second is epithelium itself can change your refractive error. Moving on to after your topography and epithelium and the tears, we need to move to the third part of it, which is heavily mathematically driven. And that's when sometimes we lose interest in this particular subject, because it's so, so much of link to astronomy, mathematics, that is sometimes extremely confusing. So in this next 5 minutes on this particular subject, I'll try to make it as simple as possible with these 4 questions. What are aberrations? What are aberrometers? How do they work? And how do you make sense of the data what we get? See, to be very simple, aberrations are nothing but anything which is deviation from normal, the imperfection of your optical system. It's very simple. So that means if your optical system, which starts with your tears out here, we need to add the tears here to the lens and beyond. If the optical system at any point of time has showing imperfection, your ray of lights will not fall in the same area as you want it to be. And that's when you change, the quality and the quantity completely differs. For example, how do we measure these aberrations? We use something called as an aberrometers. Many years back, when they were trying to study the different planets and stars, or even now, when the light was coming from those stars, there were a lot of particles in your solar system. Each of these particles used to change the path of light, and by the time you actually get it on your telescopes or cameras, it will be completely blurred. So they had to bring out some concept to reduce these aberrations, because each of those particles in the solar system was changing, it was an aberration. So that's when the aberrometers were used, and that's what we use today. And for example, all of us have from our undergraduate days, we know about the conoidostrum and the circle of least confusion. The question is, today we are able to achieve this on a machine. Most of the aberrometers actually tell you, and this is exactly, if you can look at those 2 images, it can tell you in a perfect system. What happens is these dots of light will form at this point, and you can tell them that this is how the vision of the patient is. For example, if you get this kind of an image where the lights don't actually form in one point, and ultimately you have an image which is a scatter. So aberrometers today actually can help you to actually decode and see what is actually happening in the patient from an optical point of view, from a geometrical point of view. For example, if this is not falling well, for example, this is not falling at this point, circle of least confusion, that's why you have an image which is completely scanted out. And here you're falling at that dot point, and that's why you have a crisp image. And this is actually of a patient. This is not an animation. This is actually from a patient taken from an aberrometer of 2 different patients, one with a keratoconus and one with a perfect 6x6 good quality of vision. So the question is, now we know that there are aberrations. The question is, where are these coming from? Again, this is a new change from what we knew before, because earlier is to get a bunch of data, we would not know whether it's coming from the tears or from the retina. And then we started dividing the corneal, the internal, and the total aberration. And that aberrometer started also coming in various forms. One you would, based on a particular person, Hartmann-Shack, which uses a different technology. Ray tracing, the one which I showed you is a ray tracing which uses a band of light which goes in and it traces each one of them. That's why it's called ray tracing. Skiascopy is nothing but a slit lamp based, like a slit based technology from Nidec, and Chernig from Wavelight. Each company adopted one type of one principle and started working on it. For example, when you look at this, the machine started dividing the imperfection from your cornea, the retina, and what actually goes to the brain. That means you have 3 points here, the cornea, retina, and which goes to the brain. And in this case, it's very simple. When you look at this, a person who is not happy with your quality of vision, and you can see that what is coming from the cornea, the letter E, is perfect. What is coming from the lens is perfectly irregular. And what actually goes is this image. And this person has not still developed your so-called cataract, which is in clinical sense. That means the patient is very unhappy, but he's not lead to a stage where you can operate. And sometimes it's very confusing because you cannot give him glasses because he's not happy, and you cannot give him contact lens because again it's all this complication happens. So abrometers helps to decode this beautifully, like in this picture. And what he's saying is he's got multiple images. The multiple images are coming from your lenses, and this is now. Many years back, I used to call it as a mathematical cataract. Today, I see a lot of Western people call it as dysfunctional lens syndrome, where the lens is having more aberrations and not reached the stage where it's actually become old. Now, machine gives you a lot of values. Now, what do I do with these values? That's where you need a mathematical language, because Zernike is a language. Zernike was a physicist. He won a Nobel Prize for, not for this particular one, he won for the phase contrast microscopy. He made some algorithm to convert anything which is dotted or any mathematical language to give some strength. He gave some values and shape. And using this dots and aberrations, you add a shape to it, and that's what you get it as Zernike. And that's when you get this beautiful complex thing which can scare a lot of people. It's about what are the aberrations, and each aberration has a shape, and the shape is not actually what you see in normal anatomically. It is a shape created mathematically. So that is very important. It's not like you go to a cornea and you can pick up any of this shape. You will not get this shape at any level. Any histopathology or anything, even electron microscopy cannot get its shape, because this is purely mathematically driven. And what can be corrected with glasses is the first, we call it orders, and it can go up to any order, 27, multiple combination. But machines today can check up to around 21 orders. And what you can see here is this can be corrected with glasses. When you have the one which is coma, that means your light scatters like a coma. And these are the ones which cannot be corrected. And this is how a person with a terrible aberration looks like, and how you correct it later. And this you can just see the quality of vision. The corneal biomechanics is again a new parameters which looks at how the cornea behaves, because like it's an elastic tissue. So when you're looking at how each cornea behaves differently, that means cornea which is rigid will be very strong, and the one which is not rigid will be very weak. It means it moves. The fragility of the cornea is what we measure, and that is what helps us to come to the second part of my talk, is how do you apply all this for your refractive surgery. These are all the people who are responsible for bringing these lasers. Srinivasan was awarded a gold medal by this year by Obama for his invention on bringing the laser technology. This is how he first brought the laser onto a human hair, and this is he was working with IBM then, and he was able to etch this pattern and even write this on a human hair, and that's when we realized that it's so precise that if you can do it on that, you can bring it onto the human eye. The principle works on using argon and fluoride, and it's a photoablative procedure, and then it creates a bond, it breaks the bond, and you see this, we call it plumes. What gets irradiated is the plumes, and this, you can pick it up from any textbook. The most important thing in here is this formula here of how do you correct. For example, if I'm treating a -1, what really determines how much of refractive error I correct is given by this person out here, and what we call it as a depth of ablation. That means if I had to treat a -1 and amount of tissue I ablate, maybe around 12 microns or 13 microns of the cornea, and that, how do you check and how does the machine actually look at, is from this formula given by him. We have started, this is the evolution of the LASIK surgery, and I've just kept it open here because probably this year you might see something new. Started with radial keratotomy, which makes incisions, which flattens the center. But for any refractive surgery, if you go back to what I just said, I'll just spend a minute on this because this is very important. Everything else you can get it from the books. The most important thing is having a robust diagnostics, what we just discussed here. It has to be predictable. Every new day, every single day, you will get a new technology which claims to be better than the previous, and that's where you need to be very clear about how predictable it is. And all your machines, what I just showed in the previous 15-20 slides, should talk to the machine what you treat. That means the diagnostics machine should speak to the machines what you're treating. It has to be versatile. Anything you do has to be a little bit innovative in its sense, and you have to think with the machine. Many times we assume that the machine will think for you, it will give you the diagnosis what you want, but machines cannot think. You will also have to think with it, and that's when you have a happy patient loop and change. So that 10 commandments has to be very important before we move on to this, the refractive procedures as such, because if you do not have that clear, then all the procedures, like I said in the beginning of my talk, the refractive surgery is more of science and less of art. It is not a very artistic surgery, but it's more of science. So science has to be very clear before even you get into this procedure, because, for example, PRK is so simple. You remove the epithelium, switch the machine on, it treats and done. But if you do not know the other things, the patient will end up as very unhappy as before. And these are all the types of PRKs. You can do an advanced PRK where you remove the epithelium with the lasers, with mitomycin, because when you do a PRK, what's the most important complication is that when you treat higher powers, there is a change of keratocytes to myofibroblasts, and these myofibroblasts can cause all these haze patterns out here. So when we are treating anything which is more than 35 to 40 microns, we use mitomycin on the bed, which prevents this haze. Complications can be decentration of your ablation, undercorrection, overcorrection. This we don't see too much now because the machines have become very predictable. But still, its PRK has got pain, the patient has haze, the recovery time is longer, and the patient feels that the money what they spent is not worth it, because it's too much of, it's a very cumbersome procedure. That's when the LASIK started coming into the picture. And for example, this is how it started, and this is the kind of change. What you're seeing is phenomenal. I don't need to go into this, but I'll spend a minute on this, because anybody starting with a refractive surgery, I'm not saying it's the perfect guidelines for any refractive procedures, but it is still one of the most manual for to prevent a complication. What it tells you is what are the risk factors which can actually lead to a patient having a problem later. The risk factor could be the younger age group. We try not to do the procedure before 21 years. The corneal thickness, minimum 480 microns. Refractive stability has to be at least for a year. The patient has to be free from any other systemic disorders, and all the diagnostic evaluation like tear film and other things should be perfectly normal, and try to limit the refractive correction to a stage where you do not burn too much of tissue. In this case, if you look at this paper, it's freely available in American Academy Ophthalmology Journal. What you see is that when you're trying to bypass all this, that's when you end up in problems. The microkeratome, where you used to use the blade, but it had its own problems. For example, it would have a free cap, the blade would just flip off. You'll have a buttonhole in the center of the flap, and that would again create a problem. And improper ablations. Sometimes when there was a habit of using the same blades to many patients, the epithelial cells used to get into the interface, and that would create a problem. So the next thing came was the femtosecond laser. It was safer because you're not using a blade, it's more precise. The precision was very good because what you wanted, for example, you wanted a depth of certain level, you would probably get the same depth. It was very versatile, and patients, it's good for marketing that you would say bladeless and less complications. It's nothing but using lasers. It used to create plumes, individual energy at that point, and then it would create a flap. And if you really compare the flaps between the blade and the microkeratome, this is how we would look. I don't need to explain it. Just looking at it, it's perfect alignment, and the blade would have a different thickness from each level. And that is one of the reasons why I think femtosecond became the one of the choice for refractive surgery. Evolution in refractive surgery is that, it is like, why do you want to make a cut? Why do you want to burn it? That's when the smile with small incision lenticular extraction came from Zeiss, where the entire procedure is done without actually making any cut on the cornea, with a small incision as less as around 3 microns. Probably the used procedures. This is posterior chamber intraocular lens, where you place it in front of the lenses. The new concept is bringing out, because one of the issues with us was, glaucoma and increased pressure, so we always need to have a PI. But now the centriflow technology has come where the PI is reduced. Coming to the final frontier, which I feel is still we are not conquered, is refractive surgery in a presbyopic patients. We started off with using laser, where we used to create a central 3 millimeters myopic, and the peripheral was the same. It would not touch the cornea. It would create a small bump in the center of the cornea, so the cornea would have more power in the center. So that when you're reading something, the pupil would constrict, and from that center 3 millimeter zone, the patient would have a myopic correction. It looked great on paper, but actually the patient used to have a lot of vision disturbance because you have no control on your refractive, the pupil constriction or dilatation, and they would have a lot of scatters. So then came the new concept of implanting, like in this camera implants, using a small pockets deeper around 130, 140 microns. You'll implant it, and it will work like a pinhole effect. And this is how, and it will give the depth of focus. And there are new ones which is called the raindrop implants, but again, I really don't know whether it will stand the test of time, because one thing about presbyopia is every year we get new implants coming in, and by the next year you see it vanishing. So these are the two implants which are in the market now, which kind of can be used. But however, at this point of time, if patient is very keen that he or she wants to get rid of the glasses completely, then I think still the most predictable of all this is still the patient is willing, and is refractive lens exchange, where you can use a multifocal lenses. A few things about when things go wrong, it is when we need to have a little bit of out-of-box thinking, because refractive surgery is again about trying to pick up the small signs of issues when small signs early till it becomes very late. For example, the tear quality, just comparing one with a good tear film and one with a bad tear film, the most common cause of an unhappy patient with post-refractive surgery, whether it's the quality of vision or the quality of life, is always to do with the dry eye part of it, which has to be managed very well. And when I mentioned about the Randleman criteria, this is what I was telling. If you look at this, there is a skewing, the thickness, a lot of tissue was burnt on this patient, and the most dreaded complication today of refractive surgery, when you're not very clear with your diagnostics, is ending up with the patient with an post-LASIK ectasia. And post-LASIK ectasia is something which is very dreaded, and many times if you don't treat this well, you may go for a transplantation. Flap stray is one thing which can change epithelium and also cause a lot of scatter. Sometimes, when you're trying to burn a lot of tissue in a smaller optical zone is the area where you are ablating the tissue, you end up in having a very irregular cornea. This is your pupil, the dotted lines is your pupil, and you can see that the center is 38, just outside is 37, just outside is 41 diopters. That means everywhere in your cornea in the 5 millimeter zone, you have 4 to 5 different types of keratometry readings. So what it does is the cornea, the brain is confused. It doesn't know from where the light is coming from, because this light is completely scattered. And this is exactly what happens. There is between this 3 to 4 millimeter zone, you have close to 3 diopters of change. That means every time the pupil changes, there's a change in the refractive error. So most important thing for a refractive surgeon is trying to understand how the pupil behaves to your refractive correction. So understanding the pupil diameter is very important. For example, if you look at this, if you have a 2 millimeter pupil and the light is perfect, as the pupil size increases in this patient, you have a double vision. This is very classic of patient coming to you saying that my vision is perfect in daylight, but when I go inside, I start seeing double. That's when you have to look at the pupil, and let this slide remind you that just a change from 2 to 7 millimeter pupil actually changes the person's perfect vision to a double vision. Sometimes patient comes to a double vision, we try to evaluate for squint and other things, but probably the answer might be here. So what do we do for these patients? Machines have different algorithms which help to look at treating these abnormalities. For example, this is one of those cases where the laser was not given in the area where it was supposed to give. So this ended up in a double, we don't call it a double vision, we call it ghostings or halos. And this patient ended up like this, and you can treat this patient without actually treating the refractive error. And I just, yeah. And this is one thing, even though I'll take just less than a minute because we have an instruction course on keratoconus sometime tomorrow. So I'm just saying that refractive keratoconus management is also going to be part of a refractive surgery now, because it is so much of new things in keratoconus. So it's important that the different protocols like Dresden protocol, which uses the energy, and now looking at the transepithelial, where you don't need to remove the transepithelial, all comes under the horizon, all comes under the banner of refractive surgery. And I'll just rush through this. Intax is again a procedure where you can treat the refractive error in a keratoconus using a ring, and what it does is it probably used in a progressive keratoconus, and sometimes when the patient does not want to go for a transplant and you have a good thickness, that's when Intax can be used. And these are the nomograms, and this is one where we treated where you put a single ring here, and this is after 2 years. You can see that the whole of keratoconus is kind of stabilized. So thank you.